Today, we're exploring the key ideas from It's Not Hysteria by Dr. Karen Tang. This is an independent educational overview, enriched with our own integrative analysis and actionable exercises. Think of it as a guided reflection to spark your own insights, not a replacement for reading the book itself. Introduction. Beyond the dismissal. For countless individuals, the journey through gynecologic health is fraught with unspoken suffering, a landscape of chronic pain, debilitating cycles, sexual dysfunction, or fertility struggles. This profound, often intensely private ordeal is frequently met with a dismissive wave, a casual suggestion that such discomfort is merely normal, or worse, that the source of the distress lies within one's own mind. Millions navigate this frustrating cycling through medical consultations, feeling unheard, their symptoms dictating the rhythm of their lives, while a pervasive silence, fueled by stigma and historical underinvestment, stifles any hope for clarity. This narrative emerges as a vital counterpoint to that silence. It offers not just a beacon of hope, but a practical arsenal of knowledge, empowering individuals to reclaim agency over their bodies and their health. Far from a dry medical text, it serves as a curated guide, illuminating essential gynecologic topics and equipping readers to understand their physiology, navigate treatment pathways, and engage effectively with healthcare professionals. Crucially, its language embraces gender inclusivity, acknowledging the diverse experiences of transgender, non-binary, and intersex individuals assigned female at birth, ensuring their struggles are recognized and their voices heard. Moreover, this perspective extends its address to the healthcare community itself, recognizing the dedication of providers while critically examining systemic failings within medical education that perpetuate outdated myths and contribute to delayed diagnoses. It seeks to forge a collaborative bridge between patients and practitioners, uniting them in a collective endeavor to dismantle the barriers to quality reproductive healthcare and eradicate unnecessary pain. This is a call for a fundamental reevaluation, a revolution in understanding, and an unwavering affirmation that the distress experienced is real, valid, and demands recognition. Echoes of dismissal. A legacy of neglect in reproductive health is not an anomaly, but a direct inheritance from centuries of entrenched societal and medical biases. Historically, the functions of the female body, particularly the uterus, were intricately entangled with notions of mental stability and moral character. This archaic framework laid the groundwork for a legacy where scientific inquiry often capitulated to speculative myths, leading to generations of indignities and traumas that continue to color modern perceptions and practice. Imagine, for instance, a physician in ancient Greece attributing a woman's inexplicable leg pain and melancholy to her wandering womb, prescribing a cure that involved fragrant oils to coax the organ back into place. Such concepts, though seemingly distant, echo in modern advice, like a doctor suggesting pregnancy as a remedy for persistent pelvic pain, overlooking underlying conditions. The very term hysteria, derived from the Greek word for uterus, became a catch-all diagnosis for any distressing, unexplained female symptom. This intellectual shortcut paved the way for a succession of harmful cures, from the disturbing notion of demonic possession leading to witch trials to the barbaric gynecological surgeries of the 19th century, clitoridectomies or removal of ovaries performed under the misguided belief they could stabilize a woman's volatile emotional or physical state. While these extreme practices are consigned to history, the paternalistic undercurrent endures. Consider a patient presenting with incapacitating fatigue and diffuse pain only to be offered a rest cure that confines her to bed, diminishing her autonomy and exacerbating psychological distress, rather than seeking a physiological explanation. Today, this legacy manifests in diagnoses like somatic symptom disorder, disproportionately applied to women whose legitimate physical ailments may simply defy standard diagnostic tests, subtly shifting the burden of illness from the body to the mind. A woman experiencing severe abdominal bloating and intermittent pain, for example, might be told it's just stress or all in her head, when a deeper exploration might reveal a hidden condition, like an elusive growth or subtle inflammation. Adding layers of profound injustice, marginalized communities, particularly Black women, have endured unique and persistent racial biases within the healthcare system. The historical experimentation on enslaved Black women, performed without anesthesia, under the horrifying premise that they felt less pain, casts a long, dark shadow. This systemic racism persists, evident in modern disparities. Black women face alarmingly higher maternal mortality rates, consistently receive undertreated pain management, and encounter health outcomes worsened by social stressors and even discriminatory beauty standards. A Black patient reporting agonizing menstrual cramps might be given a lower dose of pain medication or her pain dismissed entirely, a stark contrast to the treatment of a white patient with similar symptoms. Compounding these historical and social injustices, the landscape of medical research itself has historically excluded women and minorities. This oversight, combined with chronically inadequate funding for conditions predominantly affecting females, means that basic etiological understanding for widespread issues like endometriosis or fibroids remains elusive. Instead of developing preventative measures or cures, treatments often default to managing symptoms or, in many cases, resorting to the removal of reproductive organs. Furthermore, a fractured healthcare infrastructure marked by physician shortages, burnout, inadequate insurance reimbursements for women's health services, and political intrusions into reproductive autonomy erects substantial barriers to accessing quality care. A young person struggling with chronic pelvic pain might face months-long wait lists for specialists, only to find their insurance does not cover a crucial diagnostic procedure, a stark illustration of a system struggling under the weight of its own deficiencies. For equitable, compassionate, and effective gynecologic care to become a universal reality, a profound systemic transformation is not merely desirable, but an absolute imperative. Unveiling the internal landscape, navigating common gynecologic challenges. A fundamental understanding of one's own body is the bedrock of informed healthcare, yet it's surprisingly absent for many. Imagine a college student, legally an adult, capable of intricate academic thought, yet utterly bewildered when asked to identify the clitoris or explain the stages of a menstrual cycle. This pervasive knowledge gap, often stemming from deeply ingrained societal taboos surrounding sex and reproduction, hinders individuals from recognizing when something is amiss. Just as a mechanic needs to understand an engine's normal function before diagnosing a fault, grasping the intricate, interconnected systems of the pelvis, the reproductive, urinary, and gastrointestinal organs, is crucial for navigating any health concern. The internal landscape of the female reproductive system includes the delicate ovaries, responsible for egg release and hormone production, unlike the continuous sperm production in males. Fallopian tubes, with their fimbriated ends, artfully capture eggs, guiding them towards the uterus, the muscular organ engineered for pregnancy. It is within these tubes that fertilization typically occurs, a brief window of opportunity before the egg reaches the uterus, where its lining, the endometrium, thickens and sheds monthly, driving the menstrual cycle. Conditions like adenomyosis see this endometrial-like tissue inappropriately invading the uterine muscle, causing profound discomfort, while growths, known as fibroids, benign muscle tumors, can lead to heavy bleeding or pressure symptoms. The vagina, a muscular conduit, plays roles in reproduction, menstruation, and intercourse, its health maintained by a delicate microbiome. Beyond these, the external vulva, a complex and often misunderstood area, houses the clitoral complex, far more extensive and sensitive than its visible tip, serving as a primary site of sexual pleasure. The intricate architecture of the pelvis means that reproductive health is never isolated. The bladder, ureters, and urethra, components of the lower urinary tract, are close neighbors, explaining why gynecologic conditions can cause urinary urgency, frequency, or burning, even in the absence of infection. Severe inflammation from a condition like endometriosis, for example, might even obstruct a ureter, potentially compromising kidney function. Similarly, the lower gastrointestinal tract, including the colon and rectum, also traverses this confined space. A large fibroid pressing on the rectum could lead to chronic constipation or painful bowel movements. Or advanced endometriosis might fuse the uterus and rectum, leading to symptoms often mistaken for irritable bowel syndrome. This interconnectedness means that a single underlying gynecologic issue can manifest with a bewildering array of seemingly unrelated symptoms, from lower back pain to persistent digestive upset, highlighting the need for a holistic perspective in diagnosis. Many conditions frequently affect these intertwined systems, presenting unique challenges. Fibroids, for example, are exceptionally common, benign growths within the uterine muscle, affecting a vast majority of individuals with a uterus by middle age. While often asymptomatic, they can cause debilitating symptoms like excessive bleeding, severe pain, or a sensation of abdominal fullness and pressure, impacting organ function like bladder control. Imagine a person constantly needing to urinate or experiencing such heavy periods that they become anemic and struggle to leave the house. Endometriosis and adenomyosis represent invisible diseases where tissue resembling the uterine lining grows either outside the uterus or within its muscular wall, respectively. These conditions trigger systemic inflammation, leading to a broad spectrum of agony, excruciating period pain, chronic pelvic pain, painful intercourse, and the very bowel and bladder symptoms that often lead to misdiagnosis. Someone might endure years of debilitating cramps and bowel issues, constantly told they have irritable bowel syndrome, only for it to be discovered that endometriosis is causing widespread inflammation. Polycystic ovarian syndrome, the most common endocrine disorder among reproductive age individuals, presents as a complex syndrome rather than a single disease. Its manifestations are diverse and highly individualized, ranging from irregular periods and fertility challenges to hormonal symptoms like acne and excessive hair growth, and metabolic issues such as insulin resistance. Consider a teenager struggling with chronic acne, unexplained weight gain, and frustratingly absent periods, unaware that these are signs of a complex hormonal imbalance. Ovarian cysts are another common finding, with most being physiological and resolving naturally. However, some, like endometriomas or dermoid cysts, can cause severe pain or, in rare emergencies like ovarian torsion, twist and cut off their own blood supply, leading to acute, excruciating agony that demands immediate surgical intervention. Picture a person suddenly crippled by searing, intermittent abdominal pain accompanied by nausea, not realizing their ovary has twisted dangerously. Pelvic floor dysfunction, characterized by spasms or weakness in the muscles supporting the pelvic organs, is a silent epidemic, frequently underlying chronic pelvic pain, sexual discomfort, and bladder or bowel issues. Because it doesn't show up on standard imaging, it often goes undiagnosed for years. A person experiencing persistent pain during intimacy or feeling as though they can't fully empty their bladder might be struggling with overly tight pelvic floor muscles, a condition often overlooked. This dysfunction can also contribute to pelvic organ prolapse, where weakened muscles and connective tissue allow organs like the bladder or uterus to descend into the vagina, leading to a sensation of bulging or difficulty with defecation. Furthermore, urinary incontinence, whether stress-induced leakage during a cough or a sudden overwhelming urge to urinate, affects nearly half of all women at some point. These seemingly disparate conditions are often interconnected, underscoring the necessity of a comprehensive, informed approach to unraveling the individual's unique tapestry of symptoms. Pathways to empowerment: treatments, autonomy, and inclusive care. Navigating the complexities of gynecologic health necessitates a proactive, informed approach, especially given the historical propensity for dismissal. The initial step toward effective care often begins with meticulous self-assessment. Imagine a patient arriving at their appointment with a carefully logged diary detailing the exact timing, quality, and triggers of their pain, alongside their menstrual cycle phases, diet, and daily activities. This level of preparation empowers both the individual and their provider, transforming a brief consultation into a targeted investigation, focusing on their most pressing concerns. Understanding that symptoms seemingly unrelated to the reproductive system, like bowel changes, urinary issues, or mood fluctuations, are often profoundly connected, is also key to comprehensive symptom mapping. Treatment for gynecologic conditions is rarely a one-size-fits-all proposition. Rather, it's a highly individualized journey that weighs symptom severity, fertility goals, and personal preferences. For conditions like fibroids, endometriosis, and adenomyosis, the spectrum of care ranges from managing symptoms with nonsteroidal anti-inflammatory drugs, NSAIDs, and hormonal contraceptives that suppress periods to more aggressive interventions. Procedures such as uterine fibroid embolization can shrink fibroids by cutting off their blood supply, while a myomectomy offers surgical removal, preserving the uterus. For endometriosis, precise laparoscopic or robotic excision, carefully cutting out problematic tissue, is the gold standard, often requiring multidisciplinary surgical expertise. For adenomyosis, localized removal may be an option, but often complete relief for those not desiring future fertility might necessitate a hysterectomy. The emphasis always remains on exploring all options and seeking second opinions, especially if a sole, drastic solution is presented. PCOS management focuses on its diverse manifestations. Lifestyle adjustments, including diet and exercise, are foundational, with even modest weight loss often yielding symptomatic improvement. Medications can target specific issues: hormonal therapies for cycle regulation, dermatological treatments for skin concerns, or insulin-sensitizing drugs like metformin. For conditions like pelvic floor dysfunction, specialized physical therapy is paramount, guiding patients beyond simple Kegels to retrain and release tight muscles. Similarly, incontinence and prolapse benefit from pelvic floor strengthening, vaginal pessaries for support, and in some cases, surgical repairs like slings for stress incontinence or sacrocolpexy for severe prolapse. Sexual dysfunction, a deeply personal and frequently undertreated concern, requires a multifaceted approach. Recognizing that pain during intimacy, diminished libido, or difficulty achieving orgasm can stem from physical, hormonal, psychological, or relational factors, treatment often involves a team. Sex therapists can address emotional barriers and communication, pelvic floor physical therapists can release muscle spasms and desensitize nerves, and sometimes medical interventions like vaginal estrogen for dryness or specific medications for desire can be beneficial. Crucially, access to accurate information about lubricants and safe practices is vital, dispelling myths and promoting comfort. Vulvovaginal issues, from common infections like yeast or bacterial vaginosis to chronic skin conditions and changes induced by low estrogen, require careful diagnosis and targeted treatment. Understanding the delicate balance of the vaginal microbiome and avoiding harmful feminine hygiene products is critical for prevention. For conditions like premenstrual syndrome, PMS, and its severe counterpart, premenstrual dysphoric disorder, PMDD, lifestyle modifications, hormonal birth control to stabilize cycles, and specific antidepressants, SSRIs, can offer significant relief, with PMDD often requiring dedicated mental health support. The transition through perimenopause and menopause, while natural, can bring a host of challenging symptoms, from hot flashes to genitourinary syndrome of menopause. Evidence-based menopausal hormone therapy, MHT, can be profoundly effective, though individualized assessment of risks and benefits is essential, along with a discerning eye for unproven bioidentical treatments. Beyond the specific conditions and treatments, this broader perspective embraces critical life stages and social contexts. Infertility, a common and emotionally taxing journey, can stem from a multitude of factors: ovarian, tubal, uterine, male, or unexplained. Diagnosis involves comprehensive testing for both partners, and treatments range from ovulation induction and intrauterine insemination, IUI, to the highly effective but demanding in vitro fertilization. The immense emotional toll of infertility necessitates robust mental health support. Similarly, miscarriage, a heartbreaking reality for many, is rarely the pregnant person's fault, most often stemming from random chromosomal abnormalities. Understanding its commonality and the varied management options, alongside comprehensive emotional support, is vital for healing. Gynecologic health also intersects profoundly with gender diversity and intersex experiences. For transgender and non-binary individuals, gender-affirming care, encompassing psychosocial support, hormonal therapies, and sometimes surgeries, is a critical component of reproductive health, addressing gender dysphoria and fostering gender euphoria. It requires healthcare providers to create inclusive environments, utilizing chosen names and pronouns, and offering routine care without judgment. For intersex individuals, whose biological sex characteristics vary from typical binary definitions, the historical trauma of medically unnecessary infant surgeries highlights the imperative for bodily autonomy. Decisions about any interventions should be deferred until the individual is old enough to provide informed consent, affirming that intersex variations are natural, not disorders. Finally, the looming shadow of cancer in the gynecologic sphere underscores the importance of vigilance and advocacy. Unexplained weight changes, postmenopausal bleeding, or persistent bloating are signals that demand thorough investigation, empowering patients to push for testing. Cervical cancer, now largely preventable through HPV vaccination and pap smears, stands as a triumph of public health. Uterine and ovarian cancers, with their often vague symptoms, require heightened awareness and timely diagnosis. Breast cancer, a prevalent concern, benefits immensely from screening mammograms and self-awareness. Ultimately, reproductive health care is about making deeply personal choices, from birth control that offers autonomy over one's body and life trajectory, to permanent sterilization options, or the complex and often politicized decision of abortion, a safe and legal medical procedure that is a fundamental aspect of health justice. These choices, sometimes life-altering, demand respect, accurate information, and an unwavering commitment to patient autonomy within a supportive and ethical healthcare framework. These integrative analysis, a call for revolution and reimagination. The myriad of conditions and challenges explored in this landscape of reproductive health are bound by a pervasive, insidious thread, a profound and systemic deficit of information, understanding, and equitable care. The fact that conditions like uterine fibroids affect a staggering number of Black women, yet their fundamental causes and preventative measures remain largely unknown, speaks to a deeply ingrained imbalance in medical priorities. Decades have passed, yet for widespread and debilitating ailments such as endometriosis, polycystic ovarian syndrome, or the complex shifts of menopause, foundational breakthroughs in understanding their origins or developing curative treatments remain frustratingly elusive. This sustained neglect, chronically under-researched, severely underfunded, and consistently undertreated, is not accidental. It is a direct consequence of historical biases rooted in misogyny and racism that have shaped societal and medical assumptions about bodies assigned female at birth. These biases manifest in insidious ways, leading medical problems predominantly affecting individuals with uteruses to be dismissed, pathologized as psychological, or simply expected to be silently endured. The ghost of hysteria lingers, re-emerging in modern diagnostic patterns or in the casual invalidation of genuine suffering. A young person reporting incapacitating period pain might be told to just take some ibuprofen, overlooking the possibility of endometriosis, while a patient with chronic pelvic discomfort might face years of misdiagnoses, their symptoms attributed to anxiety or a fragile mental state. This perpetuates a cycle of delayed diagnosis, prolonged suffering, immense emotional distress, and often the unnecessary progression of conditions that could have been managed more effectively if recognized earlier. However, the insights gleaned from these experiences also illuminate a powerful path forward. The very act of equipping individuals with clear, accessible knowledge about their anatomy, common conditions, and available treatments is itself a revolutionary act. It empowers them to articulate their symptoms, ask informed questions, advocate for comprehensive testing, and challenge medical dismissals. It transforms them from passive recipients of care into active partners in their health journey, capable of making truly autonomous decisions about their bodies and futures. The call to action extends beyond individual empowerment. It demands a collective uprising against the systemic failures that have long defined reproductive health care. This necessitates a multi-pronged revolution. 1. Massive increase in research funding. Dedicating substantial resources to unravel the fundamental biology, causes, and effective treatments for widespread conditions like endometriosis, fibroids, PCOS, and chronic pelvic pain. This means moving beyond mere symptom management to truly understand and cure. 2. Overhauling medical education. Integrating comprehensive gender-inclusive curricula that equip healthcare providers with a nuanced understanding of diverse gynecologic conditions, recognizing the full spectrum of sex and gender, and dismantling ingrained biases against female-identified pain. 3. Ensuring equitable access. Addressing barriers such as physician shortages, high costs, insurance limitations, and the politicization of reproductive rights. This includes ensuring access to gender-affirming care, comprehensive fertility services, and safe abortion care as essential components of health justice. 5. Dismantling stigma. Fostering open dialogue, sharing personal stories, and building supportive communities that break the silence around gynecologic conditions, allowing individuals to seek help without shame or fear of judgment. 5. Prioritizing patient autonomy. Recognizing that the ultimate authority on what constitutes a good quality of life rests with the individual, and that treatment decisions must be collaborative, informed, and respectful of personal values and choices. The future of reproductive health can and must be reimagined. It is a future where anatomical literacy is universal, where diagnostic delays are historical footnotes, where suffering is met with empathy and scientific rigor, and where every individual, regardless of their sex assigned at birth or gender identity, receives the dignified, effective care they deserve. This is the unwavering declaration. It's not hysteria, it never was, and the time for a truly transformative change is unequivocally now. Actionable Exercises. 1. Your Health Story Roadmap. Before your next doctor's appointment, take charge by crafting your personal health roadmap. This isn't just a list of symptoms, it's your narrative. Start a dedicated notebook or digital document. On the first page, write down your main concern in one clear sentence. Then, for each symptom you experience, pain, bleeding, mood changes, etc., describe it in detail. What does it feel like? How severe is it? When does it happen? Is there a pattern with your cycle, activities, or food? How long has it been going on? What makes it better or worse? How does it impact your daily life, work, relationships, or mental well-being? What treatments have you tried, and were they helpful? Also, list 2 to 3 specific questions you want to ask your doctor, and what you hope to achieve from the visit. Having this organized information allows you to use your appointment time effectively and ensures your voice is truly heard. 2. Decoding your body's blueprint. The more you understand your body's layout, the better you can pinpoint what feels off and why. Imagine your pelvis as a unique landscape. Find a simple diagram of the female internal and external reproductive organs, as well as the interconnected urinary and gastrointestinal systems. Refer to Chapter 2 for guidance. Next, using colors or labels, mark where you feel specific symptoms like pain, pressure, or discomfort. Next, revisit the sections of the book that describe conditions like fibroids, endometriosis, or pelvic floor dysfunction. Do any of the symptoms or locations described there resonate with your own colored map? This isn't about self-diagnosing, but about building a stronger vocabulary and connection to your body's signals. This exercise helps you identify patterns and articulate your experiences with greater clarity, making you a more informed participant in your healthcare journey. 3. Reclaiming your normal. For too long, many have been told that pain, heavy bleeding, or other debilitating symptoms are just normal. This exercise helps you challenge that narrative and validate your own experience. Reflect on any symptoms you've had that were dismissed by others, friends, family, even past doctors, or that you've simply learned to tolerate. Write down these experiences and how they made you feel. Then consider what you've learned from this book, the historical context of hysteria, the prevalence of many gynecologic conditions, and the impact they can have. Now, firmly tell yourself, my suffering is real and it is valid. It's not hysteria, and it never was. Think about how you will articulate this conviction to your healthcare provider. You might say, I've been experiencing symptom, and while I've been told it's normal, it significantly impacts my quality of life, and I want to explore solutions. This practice empowers you to advocate for the care you deserve. 4. Your personalized treatment compass. When considering any treatment, from medication to surgery, it's vital to ensure it aligns with your life and your goals. This exercise helps you navigate those choices with confidence. Choose one gynecologic condition you are currently managing or seeking treatment for. Review the relevant sections in the book, e.g., fibroids, endometriosis, PCOS, sexual dysfunction. Identify 2 to 3 potential treatment options mentioned, e.g., a specific medication, physical therapy, a surgical procedure. For each option, ask yourself, How does this treatment fit with my fertility goals, if any? What are the potential impacts on my daily lifestyle, work, or family? What are the short-term and long-term costs, financial, time, recovery? What are my personal non-negotiables for treatment, e.g., avoiding hormones, minimal downtime? Use these reflections to formulate specific questions for your doctor about how each option suits your unique situation. Your voice is the most important one in shaping your care. 5. Building your supportive care team. The right healthcare providers can make all the difference in your journey. This exercise helps you assess your current team and build a network of support. First, reflect on your relationship with your current gynecologist or primary care provider. Do you feel heard and respected? Do they offer comprehensive information and multiple options, or do they dismiss your concerns? Note down what works well and what could be improved. Next, consider the broader range of specialists mentioned in this book. For example, pelvic floor physical therapists, endometriosis surgeons, sex therapists, urogynecologists. If you have a specific condition, research one type of specialist who could offer deeper expertise. Look for providers known for patient-centered care and open communication. Remember, it's okay to seek a second opinion or to find a new provider if your current one isn't a good fit. Empower yourself to build a care team that truly supports your well-being. That wraps up our exploration of today's book. If even one idea here gave you something to reflect on, give it a like so YouTube knows to share more with you. And if you'd like the next insight in your feed, hit subscribe. Remember, what you heard today is our independent interpretation, enriched with analysis and exercises. The full book has far more depth, so consider reading it to experience the author's work directly. Thanks for listening to DeftU Insights, where we turn great books into tools for growth.